Okay. So let's move on to the valvular congenital heart disease endocarditis one. Yeah. Right. And we start with a question on aortic stenosis. Right. Now, before we go to this MCQ, aortic stenosis is a very common problem. It's a very common problem. Now, in Sri Lanka, we see quite a lot of chronic rheumatic valvular heart disease. See quite a lot of it. But in the West, the commonest valvular problem is actually aortic stenosis. Right? Because remember, aortic stenosis has a very similar pathogenesis to atherosclerotic coronary disease and atherosclerotic vascular disease. Right? There's a very similar pathogenesis, very similar risk factors as well. I'm not going to go into details, but remember that. Right? And there's a very strong correlation between aortic stenosis, aortic calcification, and coronary artery disease. Very close relationship. And even in Sri Lanka, I'm sure in the next decade or so, we will see an increasing incidence of aortic stenosis, right? Because we don't see much acute rheumatic fever anymore. It's mostly going to, so in a little while, we'll see this increasing. Right, so let's go back to the MCQ. So the first statement is right. Calcific aortic stenosis is associated with coronary atherosclerosis. Is absolutely right. Then aortic stenosis presents with symptoms, right? And of these symptoms, syncope is an important presentation. And in the SCQ, I have asked one of the SCQs, I've asked the cause or etiology or pathogenesis for syncope. Have a look at that and answer that. So syncope, what are the other presentations? They can present with heart failure symptoms, right? And that indicates very, very bad disease, right? Significant problem if that's the case. And also they present with angina, right? Why do they present with angina, Lamai? Simply because what happens is the patients have progressive left ventricular hypertrophy. The muscle mass increases, right? When the muscle mass increases, there is loss of supply, right? It's inadequate supply. So the heart muscle, this hypertrophic heart muscle is ischemic, giving rise to angina. Another reason is, I told you that aortic stenosis is associated with coronary artery disease, right? And that again can cause angina. So that can cause angina apart from the high muscle mass can also cause angina because the supply is lower, right? There is poor supply. So these are the causes for angina, right? Okay. Now, number 3, we've talked about this, the physical signs of aortic stenosis, right? The typical sort of low volume, slow rising carotid pulse. Now, what are the treatment options available for aortic stenosis? The first thing you have to know is we do something called a echocardiographic classification of severe aortic stenosis. That's the first thing we do. So we look for evidence of severe aortic stenosis. Then මේවා මතක තියාගත්ත අත්‍යවශ්‍ය නැහැ, but better if you remember it. Sorry? Oops, sorry. So severe aortic stenosis is determined on the velocity of the aortic stenosis jet velocity, right? And also the pressure difference across the aortic valve, the pressure difference. So the usual cutoff we take, mean cutoff we take is 40 millimeters mercury. And you say it's very severe when it's more than 60. Very severe when it's more than 60, but severe when it's more than 40. Also, the valve surface area is less than 1 square centimeter, right? Valve surface area is less than 1 square centimeter. ඕකෙන් අර pressure gradient එක චුට්ටක් මතක තියාගන්න in for a MCQ that might be useful. So more than 40 pressure difference across the aortic valve. And if it's more than 6, it's very severe. Right. So this is your definition of severe aortic stenosis. This is your definition of severe aortic stenosis. And also very severe කියලාත් එකක් තියෙනවා. Now, there are other entities of severe aortic stenosis also, which I am not going to go into. Those are postgraduate. But for an undergraduate, මේක මතක තියාගත්තා නම් තව තියෙනවා okay. Low gradient කියලා එකක් තියෙනවා. Low flow, low gradient කියලා ඒව ඔයගොල්ලන්ට වැඩක් නෑ එච්චර. Right? Those are too much for you. Right? Right. Okay. Summary is that if you have severe symptomatic aortic stenosis, you need intervention. Right? There is no doubt about it. If you have severe symptomatic aortic stenosis, you need intervention. No doubt. Right. So, Ari, that is the first thing you remember, number one. Number two thing you remember is if you have asymptomatic severe aortic stenosis. So, severe symptomatic intervention, no doubt. If you have severe aortic stenosis, but the patient is asymptomatic, you do intervention if they have an ejection fraction of less than 40, right? So less than 50, sorry. Ejection fraction less than 50, right? They are going to undergo other cardiac surgery. So best response MCQ වලට ටිකක් වැදගත්, right? Or they have a positive exercise stress test. Now මේක සාමාන්‍යයෙන් මේක ලංකාවේ වැඩි කරන්නේ නැහැ මොකද මේක ටිකක් ලෙඩක්, right? Because there is a risk of undergoing patients to with aortic stenosis stress test. ඒක කරන විශේෂ විදියක් තියෙනවා, don't worry about that. But for your purposes, remember asymptomatic aortic stenosis you do if the ejection fraction is less than 50 or the patient is undergoing some other cardiac surgery. Also there is other recent evidence that says that there are certain other echocardiographic parameters මෙතන ලයිස්තුවක් තියෙන ඒවා එකක්වත් මතක තියාගන්න ඕනේ that might also indicate intervention. හරි ඒවා මතක තියාගන්න ඕනේ. So for your purposes මෙච්චරයි මතක තියාගන්න ඕනේ undergraduate final exam එකට. Number 1, you intervene in aortic stenosis if they have symptomatic severe aortic stenosis, no doubt. And severity classification එකේ කොටසක් මම කිව්වා. Number 2, you also intervene if they have asymptomatic severe aortic stenosis, if the ejection fraction is less than 50 or they are undergoing cardiac surgery, right, for something else. Right. LV dysfunction is an absolute contraindication to aortic valve is wrong, right? Take a Baradi, that is completely wrong. Balloon valvotomy is a treatment of choice. So remember, we do not do balloon valvotomy in aortic stenosis, right? The two ways are you either replace the aortic valve open surgery or you do something called TAVI. In patients who cannot undergo open heart surgery, we do TAVI. TAVI කියන්නේ මෙන්න මේක. It's a minimally invasive technique where you sort of do a transcutaneous aortic valve implantation. මෙන්න මේ වගේ තමයි ඔක කරන්නේ. catheter එකක් දාලා aortic valve එක replace කරනවා. Right, like that. It's called TAVI. Right, and this is very useful for people who can't undergo major cardiac surgery. This is very useful, very useful. Right. Any questions about aortic stenosis?
Sir, if they are symptomatic but don't meet the severity criteria, do you intervene?
නෑ ඒක මෙහෙමයි. ගොඩක් patients when they are symptomatic they will have severe AS, most of them. Right? It's an exception that they don't. If they are symptomatic they will almost always have severe disease. Yeah?
Okay, sir, got it.
එහෙම නැත්නම් ඉතින් you need an expert opinion for that sort of thing. Because you have to say the symptoms could be due to something else. So you get syncope, heart failure, and so you have to look for other causes and you have to be very careful. So that's a different story. Yeah. Right. Okay. Good. Right. So let's go to mitral.
Sir, excuse me.
Oh, sir.
Sir, after this balloon surgery, does it work like a normal valve or will there be a regurgitation?
ගොඩක් වෙලා regurgitation පොඩි එකක් එන්න පුළුවන්, but this is very successful. ඔක දාම සාමාන්‍ය වැඩ කරනවා. හරි? But you can get a little bit of regurgitation depending on the operator. හරි?
Okay.
Okay. Right. Now this MCQ is on mitral stenosis. As you know, the commonest cause of mitral stenosis is rheumatic valvular heart disease. There is no doubt about that. So කාටවත් ඒක වරද්ද ගන්න බෑ MCQ statement එක. That is absolutely true. Hurry. Can present with hoarseness of the voice. That is a bit of a funny one, but I will show you. Right. Now, I'm sure this X-ray might be familiar. I think I've shown this to you during an OSCE class. So here you see that in mitral stenosis, there is left atrial enlargement. How you see that on the X-ray is a straight left heart border. So when there is left atrial enlargement, you see a straight left heart border. Usually the heart border is like that. This is now a straight left heart border. Another thing is the left atrium sits right there. So, and this is where the bronchi sort of bifurcates. So bifurcates. So the left atrium enlarges, the bronchi are pushed to the side. Pushed to the side. There is another thing where in this small space, you can see this aorta here. This is the left atrium, bronchi. Space here, this is the recurrent laryngeal nerve. Alright? Because it goes under the aortic arch. This is the aorta. Alright? This is the left atrium, bronchi. Recurrent laryngeal nerve. So, as an unusual consequence of mitral stenosis, which causes left atrial enlargement, it gives rise to hoarseness of the voice, right? Because it presses on the recurrent laryngeal nerve, right? It's called Ortner's syndrome. Ortner's syndrome. Sometimes, make an additional point, the left atrium becomes so big that it presses on the esophagus posteriorly and can cause dysphagia. There is a name for that. Surgery dysphagia lusoria. And it MCQ. So mitral stenosis gives some size. Okay, if it's a massive left atrium, it can give rise to dysphagia as well and hoarseness of the voice because of the compression of the recurrent laryngeal nerve. So this is just anatomy, but take a product clinically related to mitral stenosis. Any questions about that? Now, I told you during your clinical appointments that mitral stenosis causes a rumbling, low-pitched mid-diastolic murmur, right? And a loudest one. So the murmur is what you get. Here, rumbling low-pitched mid-diastolic murmur and the S1. Then you get the S2 and an opening snap. Opening snap. Right? The opening snap is generated when the mitral valve opens. Right? Opening snap, as the name suggests, it is generated when the mitral valve opens. Right? In order to hear an open, this also can be an important MCQ point, true false. In order to hear an opening snap, the mitral valve should be pliable. Should be very pliable, movable. If the valve is calcified and very stiff, it doesn't cause an opening snap. So, in order to hear an opening snap, the word we use is pliable. The valve should be pliable. Right. So, that is the opening snap. Now, the tighter the stenosis, the opening snap comes quicker. It comes closer to the second heart sound. Right? Tighter the stenosis, it comes closer to the second heart sound. Why is that? because of this. Tighter the stenosis, the left atrial pressure is high. Tighter the stenosis, the left atrial pressure is high. Left atrial pressure is high කියන්නේ මොකද? It forces open the mitral valve earlier. Right? So the tighter the stenosis, the left atrial pressure is high, right? Massively elevated, and that immediately when it gets the chance, pushes open the mitral valve early. So the shorter the gap between the second heart sound and the opening step, the tighter the stenosis. So the more severe the stenosis. So mitral valve stenosis, higher left atrial pressure, opens the valve quicker. Right. So that statement is wrong. I think it says directly proportional. Anyway, shorter the stenosis, more severe the moment. So it's inversely proportional. Right. Now, mitral stenosis management again is complicated. The only thing you should remember is severe symptomatic mitral stenosis, we do interventions on. Right? And you can do valve replacement or go for something called PTMC, right? PTMC. So PTMC is again you put a balloon and dilate the mitral valve, PTMC, right? Balloon ekak දාලා dilate කරනවා. So common sense should indicate that if the valve is very calcified, thick, balloon එකක් දාලා dilate කරන්න බෑනේ. You can't dilate it because it's so stiff and calcified. So patients with calcified valves cannot undergo PTMC. Right. Another thing is that patients with significant regurgitation, additional to the MS, patients who have MS and MR, can you do PTMC? Balloon එකක් දාලා dilate කරොත් මොකද වෙන්නේ? What happens if you put a balloon and dilate? The MR gets worse. The MR gets worse, right? So you should not offer PTMC to patients with significant MR with MS, right? So that is the story there. So patients with severely calcified mitral valves cannot undergo PTMC because balloon එකක් දාලා dilate කරන්න බෑ. It's so stiff you can't open it, right? It's so stiff. Right. Okay. Now, statement number 4, remember AF is a common complication of MS. Very common. Very common complication. All patients with MS and AF should be offered anticoagulation. All කියන නිසා වැරදි නේද? ඒක ටිකක් මෝඩ statement එකක්. All නෙවෙයි ඉතින් contraindication එකක් තියෙනවා නම් දෙන්න බෑනේ. හරි contraindication එකක් තියෙනවා නම් දෙන්න බෑනේ. So, but remember that if there is no contraindication, yes, definitely, there is MS and AF, you have to give anticoagulation. If there is some contraindication, what do you do? There's an interesting thing that they do now, which is called a occluder device. Sorry. Now, why do you give anticoagulation to prevent stroke? ඒක නිකන් net එකක් වගේ දානවා atrium එකට so that even there is a clot it doesn't embolize. There is a small net like thing that they put in. It's called a left atrial occluder device. So patients who have AF with MS and cannot have anticoagulation ඒ වගේව දානවා සමහර වෙලාවට. හරි. So MS very common problem because of chronic rheumatic valvular heart disease, and I've gone through some of the important things for a final level that you need to know about clinical features and management. Any questions? ප්‍රශ්න තියෙනවද?
Sir, valvular AF we don't put Chadwick can look at the
so valvular උතර වචනේ බොහොම වැදගත්. I will emphasize again when we do AF. Valvular AF specifically refers to patient with mitral valvular disease, right? And that of course it's MS තමයි එතන වැදගත්ම කතන්දර. So if you say valvular AF, if they have aortic regurgitation and AF, that doesn't come under that group, Tisura. Sorry. So to say valvular AF, they have a mitral stenosis most of the time, or sometimes mitral area, but mostly mitral stenosis තමයි ගන්න. And because of that confusion, we don't use those words anymore. හරි, valvular non-valvular කියන වචන දැන් පාවිච්චි කරන්නේ නැහැ because of this confusion. හරි?
එතකොට sir, now my question was then since we don't use those scores, how do we decide at what
So if the
stage
patient
do
is
we decide the
severe MS with AF, you have to anticoagulate them.
No, you were talking about contraindications, sir?
Oh. So any contraindication to anticoagulation, this is.
So is there a specific score for that, sir?
Yes. So you have to anyway go through the contraindications. There is a score called Hasbled score. HASBLED. Hasbled කියලා score එකක් තියෙනවා. ඒකෙන් that just assesses the risk of bleeding with anticoagulation. So sometimes we look at the Hasbled score and sort of decide risk versus benefit. හරි? ඒ වගේ කරන වෙලාවල් තියෙනවා.
Right, sir. Thank you.
Okay. Question number 3 is on aortic regurgitation. Now, aortic regurgitation can be acute or chronic. And this table gives you the acute ones and the chronic ones. An important thing to highlight here is that aortic regurgitation, and for that matter, MR also, is seen in patients with collagen disorders like Marfan's or Ehlers-Danlos, as well as patients with connective tissue disease like rheumatoid, right? Spondyloarthritis. Over patients you see these aortic regurgitation, chronic aortic regurgitation. So aortic regurgitation is known to occur in patients with Marfan syndrome, true. Is associated with spondyloarthritis, true. The third one, what is the clinical manifestation of AR? I told you that AR, well, they get a hyperdynamic circulation. They have collapsing pulse. All of these things I told you during your clinical appointments. And the murmur is an early diastolic murmur along the aortic sash. මතකයිද aortic sash එක මම කිව්වා? Aortic area and mid left sternal edge. That is where you hear the aortic regurgitation. What is this mitral region diastolic murmur business? Remember that? So that is the Austin-Flint murmur. Now, this picture, you can see that when the aortic regurgitation happens, the jet is like this, no? So the one I've drawn is the jet, and this is the mitral valve. So what can happen is this jet can hit the mitral valve, can hit the mitral valve and close it. Right? Can hit the mitral and close it off. So you can get a like a MS එකක් වගේ තමයි එතකොට නේ. Like a mitral stenosis murmur එකක් එනවා because the valve is closed off because of the jet. So here also you can see that hopefully මේ බලන්න මේ aortic මේ jet එකෙන් මේ mitral valve එකේ වදින එක මේ තියෙන්නේ. This is the mitral valve here. So you can see that hitting the mitral valve. So that is called Austin-Flint murmur. It indicates a severe AR. Severe AR එකක් කියනකොට තමයි this jet goes and hits these are the mitral leaflets. This is the left atrium. ඒක එන්නේ. So Austin-Flint murmur. So it is a mid-diastolic murmur in the mitral area. The main difference between this and MS is you don't get a loud S1 in an Austin-Flint murmur. If somebody asks you in the short case, you don't get a loud S1 because obviously you don't. The loud S1 in MS is due to that sudden active closure of the mitral valve because it can't float up and close as usual. Right, so that is that. Okay. Now, we also talk about a whole load of peripheral signs of aortic regurgitation, which are due to this hyperdynamic circulation. This is due to the hyperdynamic circulation. එතකොට මේ බලන්න මේකේ තියෙනවා all the signs here, right? And this guy who is Abraham Lincoln, I'm sure you know, was supposed to have aortic regurgitation, had most of these peripheral signs. So in this MCQ, capillary pulsations, that is Quincke's sign. Corrigan's sign is visible carotid pulse, right? And then you have lots of other things like Demus's sign, like head nodding with the pulse. Right? Duroseus sign is this to and fro murmur across the femoral artery that you can get in systole and diastole. Right? We discussed some of these during your clinical appointments. Right. Now the last one is a slightly difficult thing, right? Slightly difficult thing. These things like collapsing pulse, high volume pulses, all of these are seen in chronic AR, but not really in acute aortic regurgitation, right? So the fifth one is wrong. You don't see this hyperdynamic sort of circulation in acute aortic regurgitation. There's a complicated reason for that. I don't want to go into that for the moment. In acute aortic regurgitation, they get vasoconstriction, and that's a sort of whole different problem. But remember, you don't see those signs in acute AR. Right. Any questions? Got it. Okay. The next question is on mitral regurgitation. Mitral regurgitation. Right. So mitral regurgitation, what is the commonest cause of mitral regurgitation worldwide is this myxomatous degeneration of the mitral valve. That is the commonest thing. So most of your MR is due to mitral valve prolapse or myxomatous degeneration related MR. That is true. The typical physical sign of MR is a pansystolic murmur which radiates the axilla. But I told you in your appointments, hopefully, that if there is a mitral regurgitation with a posterior leaflet involved, there are two leaflets. If it is only the posterior leaflet that is involved, the murmur can radiate towards the left sternal edge in the opposite direction. Axilla එක පැත්තට තමයි ගොඩක් වෙලාවට යන්නේ, but if there is a isolated posterior leaflet involvement, it can radiate the other way. It can radiate to the left lower sternal edge, right? So මේක වැරදි නෑ, මේක හරි, but remember that point also somebody asks you. Right. Can mitral regurgitation lead to right heart failure? The answer is yes. The answer is yes, it's true. කොහොමද ඒක වෙන්නේ? Right. Now, when you have mitral regurgitation, or for that matter, mitral stenosis, it gives rise to increase in the left atrial pressure. Right? Increases in the left atrial pressure. What that causes is, increase in the left atrial pressure is reflected onto the pulmonary venous pressure. So when the left atrial pressure increases, the pulmonary venous pressure increases. It reflects back and back. So when the pulmonary venous pressure then that causes increase in the pulmonary capillary wedge pressure. So pulmonary venous, so the left atrial pressure increase gives rise to increase in the pulmonary venous pressure. That gives rise to an increase in the pulmonary capillary wedge pressure. And that with time gives rise to increase in the pulmonary arterial pressure and pulmonary hypertension. Pulmonary hypertension. That gives rise ultimately to pulmonary hypertension. Oops, sorry. And pulmonary hypertension can lead to right heart failure. So that is true. Pulmonary hypertension can lead to right heart. Right. So that is a it's a cascade or a series of events because of this back pressure, right? Increased left atrial, the increased pulmonary venous pressure, increase in the pulmonary capillary pressure and pulmonary arterial pressure. Pitipasata, it is a cascade of events that goes on. Right. Again, like your other valvular heart diseases, if a patient has symptomatic severe mitral regurgitation or coma deficiency, they have to undergo intervention. But remember, valve replacement is not the only method of intervention. So, valve replacement valve replace there are lots of minimally invasive techniques now for valve repair. You can just repair the valve, right? You don't have to replace the whole thing. So that is something that you can use. The last one, ignore that, right? Don't worry about that. Any questions about that? MCQ. So these are the MCQs on the main valvular problems, right? Main valvular problems. Right. Okay. Right. Question number 5. So now we are moving on to infective endocarditis. Infective endocarditis. These are just true-false MCQs again. Incidence is highest in injection drug users. Right. So no, obviously these people get endocarditis, but it is people who have pre-existing cardiac disease like congenital heart disease. That group has the highest incidence, right? That is sort of most of the patients with endocarditis, they have pre-existing valvular problems or congenital heart disease. A group. IV drug users do get endocarditis, but it is not the highest incidence. Among all cases of endocarditis, it is not the highest, right? So that is false. The most commonly affected valve is the aortic valve. Ekat වැරදි ගොඩක් වෙලාවට අපි දකින්නේ mitral valve involved. So these are just facts. Right. Now, I have taught you that there are several peripheral stigmata of infective endocarditis. There are various peripheral stigmata. Splinter hemorrhages on the top left. These are splinter hemorrhages. Janeway lesions. Osler's nodes, very painful nodes in the sort of hands and feet, right? And sometimes you can get these hemorrhages. And inside, rot spots, right? Rot spots in the retina. So these are all peripheral stigmata of infective endocarditis. Peripheral stigmata. හැබැයි ළමයි splinter hemorrhages are not pathognomonic. The word pathognomonic is මේක තිබ්බොත් අනිවාර්යයෙන්ම endocarditis කියන එක. Splinter hemorrhages in the nails are pathognomonic is wrong. They are suggestive when you take it with the whole clinical picture, but they are not pathognomonic. They can occur in other conditions like vasculitis. People can get splinter hemorrhages. So it is not 100% related. ඒක තමයි කියන්නේ. Right. Now a word about right-sided endocarditis. Take MCQ විදියට important. Now right-sided endocarditis we see a lot in IV drug use. Right, that's very common. The patients use IV drugs because they're directly injecting their whatever bacteria into the right circulation. So that is very common. So right-sided endocarditis is seen in patients who are on IV drugs. Right. The interesting thing about right-sided endocarditis is sometimes you don't hear a murmur. Right. Now, when you're talking about endocarditis clinically, you are looking for a murmur. Always you are listening, actively looking for a murmur. But in patients with right-sided endocarditis, you might not hear a murmur. The reason for that is that right side එක කොහොමදත් murmurs are not very prominent because of the low pressure. On the right heart, the pressure is very low. It's about 15-20 millimeters of mercury. So they don't get any loud turbulent flows because of the low pressure system. So in general, in right heart disease, valvular disease, murmurs are not loud. So similar case if there is right-sided endocarditis. Hi. Okay. Then there are lots of etiological factors related to endocarditis. Now, of all the organisms, the commonest fellows are this group A beta hemolytic streptococci, right? That cause this oral cavity in all these streptococci, right? Those are the fellows that cause endocarditis commonly. Habei sort of viridans group of streptococci, those are the fellows that cause endocarditis. Viridans streptococci. Right. Now, there are certain other organisms like Staph aureus. Now, there's an important thing to remember for MCQs about Staph aureus endocarditis. Number one, it is common in drug users, and Staph aureus can cause a very aggressive acute endocarditis. Very aggressive acute endocarditis. So, common in IV drug users because they introduce the organism of the skin. Staph aureus could have skin. There are other groups of staphylococci like coagulase negative staph in the skin. So they introduce them actively into the circulation. So that is so it's risky in high IV drug users. So that is what they get. And it causes a very aggressive acute endocarditis as well. The third point to remember is that Staph aureus is well known to affect normal endocardium, right? There is no need for the patient to have any valvular or congenital heart defects because this organism can affect the normal endocardium. So those are three important points about Staph endocardium. Another thing is treatment is difficult and we use drugs like vancomycin, right? Some people use rifampicin as well for Staph now, but in Sri Lanka that hasn't gone into practice. We use vancomycin quite a lot. The final thing to remember about Staph aureus endocarditis is very common in prosthetic valve endocarditis after valve replacement surgery, especially in the first year. Is quite common. Prosthetic. So lots of MCQ related points about Staph aureus endocarditis. Right. So the viridans eka kata kara, Staph kata kara. The other thing to know is this enterococcal endocarditis. And there's another fellow called strep bovis. These are associated with bowel cancer. Right? So that is another point to remember, organisms causing endocarditis. So enterococcal as well as strep bovis endocarditis is associated with carcinoma of the bowel. Hi. Any questions about this one? Q5? Because the enterococci live with the bowel, when there is a cancer, they can cause hematogenous spread into the heart. Strep bovis tamai. Right. Okay. Good. So moving on to question number 6. First one we already know, right? Now here I have also given you a list of things to read. This list of culture negative endocarditis. Causes of culture negative endocarditis. Especially remember this fellow, Coxiella, Hasek organisms, which is a group of organisms, Namtica, and Brucella. These are well-known causes of culture negative endocarditis. Right? For MCQs, that is very important. Right. So Coxiella endocarditis, positive blood cultures, Amarui. It is commonly caused a culture negative endocarditis. Right? Kalaturaking, they can be culture positive, but that's rare. Most of the time, it's diagnosed by serology, right? Because they are culture negative most of the time. Kalaturaking, they can cause positive cultures. ඒ කාලතරේ positive වුණ ගමන් that's significant. හරි? That's very significant if you catch it. But it's very very rare to catch it. හරි? මේක මේ MCQ පොඩ හදාගන්න is commonly diagnosed or something. එතකොට ඒක clear better. Right? Coxiella can cause culture positivity rarely. ඒක පොඩ්ඩක් එතන ලියා ගන්න. Right. Now, how do you diagnose endocarditis? Again, I'm not going to spend a lot of time, but it is this modified Duke's criteria that people use, right? And in that, you have within the major criteria, demonstration of the microorganism, right, is one big major criteria, and then imaging criteria. And this just used to be echoes, right? Echoes, but now people include PET scans as well and MRIs, cardiac MRIs. Not that these are available in Sri Lanka for endocarditis diagnosis, but they are also included in the criteria. I mean, imaging criteria, echocardiogram and also cardiac imaging, cardiac MRI or CT scan and PET scan. But echo is still what we do in Sri Lanka. And you have the whole list of culture positivity. Single positive blood culture for Coxiella is also a criteria, but that's rare. Most of the time we diagnose it with antibodies. Right. Now, looking at the echocardiograms, transesophageal echo has a higher sensitivity for diagnosing and higher specificity for diagnosing endocarditis. It is especially good for prosthetic valve endocarditis. Point එකක් මතක තියාගන්න MCQ point එකක්. This transesophageal echo is especially good for detecting prosthetic valve endocarditis. ගත වෙන ලියා ගන්න. Right. Now, all of you will remember that a basic principle of managing endocarditis is to start them on empirical antibiotics as soon as you take some blood cultures. As soon as you take some blood cultures, start them on empirical antibiotics. And there is a way of taking blood cultures also, which is detailed in this, right? Criteria, but mataka tiyaganna, we still do take multiple sets of cultures, but within 1 hour. That is the current recommendation. ඉස්සරෝක පැය 12ක් ඇතුළත ගත්තු කතන්දරයක් තිබුණා. But currently guidelines are shifting, saying take multiple sets within 1 hour. But as soon as you take something, just give the antibiotic. Don't wait for a long time to start, right? So you need to start empirical antibiotics as soon as possible. But take many sets during the first hour. Hari. Last one is on antibiotic prophylaxis for endocarditis. So this gives you a list of indications for prophylaxis. Then balanne එක කියෝලා this is a very important MCQ point. Currently, we only recommend endocarditis prophylaxis for people who have a prior history of endocarditis. Right. The second one is not very common in Sri Lanka, but valve disease in a transplanted heart, take a Lankaවට අදාළ නැහැ. Unrepaired cyanotic congenital heart disease or incompletely repaired congenital heart disease. Right? Yeah. Then any prosthetic material, right? Valve or congenital heart disease, conduits දානවා, කෑලි high කරනවා. Any of those prosthetic materials will also be indicated for prophylaxis. Right? So this is wrong. And also, the guidelines are very restrictive now. Say that you only give prophylaxis for these conditions. Conditions අපි කීපයක් බැලුවා. When they have manipulative dental procedures. That is the only indication according to guidelines. Manipulative dental procedures. Catheter දානකොට, endoscopy කරනකොට, they know නැහැ. That is what they are saying. Right? So you do it only for manipulative dental procedures. That is the guideline. Some people practice a different way, but exam එකේ guideline එක අනුව තමයි MCQ එක හදන්නේ. So that is the guideline. So only in these categories of endocarditis of risk groups that you give prophylaxis, and only in manipulative dental procedures. Any questions about question number 6, Lamai?
Sir, for that, excuse me, sir. For the dental procedures, sir, we need to give it following the dental procedures or
before?
Okay, sir. Thank you.
I'm sorry, I forgot to answer Chamanta's question. So in SBR2 heart failure වගේ තිබිච්ච යාගේ yes time එක බලන්න නැතුව ඒක කරන්න ඕනේ because that is indicated and better off with PCI and you can't give thrombolysis as well. චමත්කා තවට අමාරු ප්‍රශ්නයක් කරනවා ඔක්කොම ගත්තොත් sprint table Jane variation Rothschild all of them pathognomonic. It's a very difficult thing to answer. Roth spots can occur in leukemia also, so that is not pathognomonic. Possibly Jane variations and osseous nodes are pathognomonic, but osseous nodes to vasculitis or so I don't think any of these in isolation are pathognomonic. Right? But that's a bit of a different question. Right? So this is all prophylaxis, and prophylaxis this is primary. All these are primary prophylaxis, except of course if they have this prior history of endocarditis, it is secondary. All of the others are primary prophylaxis. Right? So there is no basis to have a gap between blood cultures. Current recommended treatment take them as the only recommendation, don't delay antibiotics because of cultures. That is the principle. ඔය කාලේ වැඩිපුර ගන්න එකේ rationale people think that එක එක කාලවලදී ගන්නකොට you can catch the organism better blah 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 nonsense, but now we say take it as quickly as possible. Don't delay antibiotics because you want to take cultures within a particular period of time. Right? Right. Right, so now a few MCQs on congenital heart disease in adults. I'm sure pediatrics will meet a detail over Hanava, right? But I'll just go through this and just tell you the answers. Right, true or false regarding congenital heart disease in adults? ASTs are usually asymptomatic, absolutely right. Right? කිසිම symptom එකක් නැහැ ගොඩක් වෙලාවට. Left. What you see on ostium secundum AST is a left axis deviation with a right bundle branch block. Right? Coarctation or rib notching matakaine, that is true. And also you see this. This is the typical X-ray figure of 3 sign, you know. And also this is rib notch. You can see the rib notching there and there. Right? And rib notching is due to the sort of the collateral circulation which is formed through the intercostal arteries. And මෙතන මේ MCQ එකේ තව අහන්න පුළුවන් දේවල් මම දාලා තියෙනවා like this is associated Turner syndrome. That's a very famous MCQ point I think in pediatrics, so Turner syndrome associated වෙනවා කියන එක. And coarctation daughter have a higher risk of berry aneurysms in the brain, so they can get subarachnoid hemorrhage. So ඔක්කොම tree falls වලට ලේසියෙන් අහන්න පුළුවන් දේවල් ටිකකුත් මම මෙතන දාලා තියෙනවා. Right. Tetralogy of Fallot can be associated with coronary artery abnormalities. That is right. Right. Aberrant coronary origin එකක් එන්න පුළුවන් in top. Last one is, I told you in the short case discussions in your appointments, if you have a cyanotic patient for your short case, if they have pulmonary hypertension, that is Eisenmenger syndrome. If they don't have pulmonary hypertension, that is TOF. Right? Because in TOF, they cannot get pulmonary hypertension because their pulmonary blood flow is extremely low, right? Very, very low. So they cannot get pulmonary hypertension. Right. Again, the CQ here is on aortic stenosis. So please attempt to answer that. And endocarditis can the CQ එකක් තියෙනවා. හරි ඒක කරන්න ඒවා නිකන් අතහැරලා දාලා යන්න එපා, but I don't have time to discuss everything. I'm prioritizing the MCQs. We'll do some MCQs, 1 or 2 sessions later at the end. All right. Any questions about that one?
Excuse me, sir. Regarding the antibiotic thing,
yeah.
Our question is after the first set of cultures start empirical and eka through the gun.
ඔව් true ගන්න. ඒක true ගත්තට කමන්නේ. Yes.
ඒ කියන්නේ අර කල්චර්ස් තුනම ගන්නකම් ඉන්න ඕනේ නැහැ ඒතකොට.
නෑ නිකන් ඉන්න ඕනේ නෑ.
ආ ඕකේ. thank you.
සර් රුමටික් heart disease තියන අයට එතකොට දෙනවද prophylaxis indications වල එක
නෑ. So now Pansal, that's an important question that you raised. දෙන්නේ නෑ unless අතර list එකේ නෑනේ. ලංකාවේ ඔයගොල්ලෝ දැකලා ඇති දෙනවා. I'm sure you have seen this happening in Sri Lanka. Now there is a reason why we do that is that ලංකාවේ අපි වෙනස්නේ හරිම. ලංකාවේ the actual cost of treating somebody for endocarditis is much higher than just giving a tablet of amoxicillin. හරිද? and antibiotics උත් මහා වැඩ කරන්නේ නැහැ. අපි දන්නෙත් නැහැ. ඔය වගේ ප්‍රශ්න තියෙන නිසා අපි නිකන් දෙනවා ඒක. but guideline එක recommend කරන්නේ නැහැ. but ලංකාවේ because if somebody නිකන් පොඩි chance එකක් හරි තියෙනවනේ මේ මිනිස්සුන්ට endocarditis හැදෙන්න. නේ පොඩි chance එකක් හරි තියෙනවා. ඒ chance එකට antibiotic දෙන්න වියදම් කරනවට ලේසි උට amoxicillin පැත්තක් දෙන එක. ඒකයි. අපි දෙන්නේ. but it's not recommended in the guidelines. so MCQ එකට ඇහුවොත් වැරදි. හරි but practice වල ඕක දෙනවා අපි දුන්නා. හරි